Hey, it's me, Jen, again, and today we're joined by a physician who offers 3 different non-surgical interventions for thyroid nodules. We'll be joined by Dr. Iftikhar Malik coming up. After struggling with his own thyroid problem, Dr. Malik grew very passionate about helping patients with their thyroid health. He is one of a select few physicians in the United States offering 3 different minimally invasive procedures for thyroid nodules. Today, we'll primarily discuss laser ablation and how this technology is becoming a mainstream treatment option in the United States for shrinking thyroid nodules.
Because thyroid is my passion, I really love it. I mean, even if I have a chance to do everything all over again, I won't do anything different.
You told me when we were speaking on the phone that you had a thyroid problem yourself, and that kind of propelled you into this field of thyroid medicine. Would you mind sharing that story with me?
I have to go a little bit further back. When I was in Pakistan, I was trained into pulmonary medicine. I really loved it, actually. I really loved it. So the plan was that after a couple of years of residency in the United States, I will go into the pulmonary and critical care. I was working over here in Wisconsin, and I ended up having my thyroid swell up significantly, and I was having fever with chills, and I was in a terrible shape. Actually, I lost 20 pounds in 10 days.
Oh my goodness.
It was kind of a very strange situation. I had to diagnose myself. I took care of it. And then this is where I started to kind of develop the interest in the thyroid. And I was employed as an internal medicine. ThedaCare was my employer, and they knew my interest. And so they offered me if I want to be an endocrinologist. This is how it started, that I interviewed at a couple of places and decided to go to Medical College of Wisconsin in Milwaukee. And I got my training in endocrinology, and I was very blessed to be a part of not only the medical endocrine team, but also one of the best surgical endocrine team in the United States, in fact, in the world, actually. So I had already pre-existing interest in thyroid. But when I encountered Dr. Doug Evans, he's a world-renowned surgeon, endocrine surgeon. So I used to listen to his lectures. Whenever he was at a case conference, I would listen each and every word from him. I learned a lot from him, and I brought that knowledge over here, started from scratch, the whole program. I have a lot of weaknesses. I have one quality that I never stop learning. There's no end to it. This is where I am today. This is my asset. So I always wanted to see what can I do more, where I can learn better to improve the qualities of my patient's life and how they feel about it. Thyroid gland is a very mystic gland, actually. I mean, there is no 2 plus 2 is 4. I mean, there is some gray area. You cannot explain few things just based on how the levels are and how the ultrasound is looking and how the patient is feeling. You cannot have that feeling until you have the thyroid problem yourself. Although that my thyroid issue resolved, I still cannot wear a tight collar. I just feel joking. My thyroid is normal size. Can somebody explain that? No, there's no way I can explain that. But there are a lot
I
of things.
understand that completely. I've had so much reduction in the size of my thyroid, but I'm very sensitive to anything touching my neck,
Absolutely.
even now.
People will not see me very often in necktie. I try to understand where the patient is coming from. And I believe that in spite of trying, there are some 1 to 2% of the patient that I still don't understand, and I am not able to help them. But I'm going to keep on trying to learn more and more things.
And I know patients appreciate that, because that patient who, in spite of having normal levels and still not feeling well, is like you, they're on a mission to always understand and learn, is there something else I can try or do to feel better? And that's what's so wonderful about being able to treat thyroid nodules without surgery, is the fact that this patient, by addressing the nodule directly, allows the patient to continue to seek that knowledge and work towards better thyroid health without losing the thyroid to surgery.
I know it is getting in the mainstream, and it was getting quite a popularity since I've started. I think it's just not even a single day. Somebody's calling and asking,
Wow.
With respect to the lasers, I think I've done the most in the country, actually. Radio frequency, I've not done as much. A lot of people have done much more than me. But it does offer a very interesting and very less invasive and with better outcomes, actually, to be honest with you, in comparison to surgery. I have a surgeon who's my partner and endocrine surgeon. This is what we do. We want to offer the best plan for the patient, and she's on board with this. They want to have laser or the radio frequency, or they want to have surgery. In certain situations, we guide patient that if the laser or radio frequency ablation is not going to be helpful, for example, if somebody have 6, 7 nodules and all of them are big, how many nodules are you going to ablate? In those situations, you can. In those situations, I think you're better off having the surgery done, in my view. But if there is a single nodule or a couple of nodules, like I had a patient today, she have 2 nodules, one on the right, one on the left, and both of them are pretty big. For some reason, she have a vocal cord paralysis on one side, and she doesn't want to go for surgery. She's afraid. And the nodules are so big that it is causing compression of the trachea, difficult for her to breathe, difficult for her to sleep.
I've been there. That's terrible.
Terrible. It's a terrible feeling. I had that feeling when my thyroid was swollen. I mean, I understand how it feels. So these are the very good patients where you can help these patients to have an improved quality of your life with a minimal invasive procedure.
The question would have for you regarding the patient, you mentioned the hypothetical patient with the 7 very large nodules. If that patient comes to you and your professional opinion is that maybe they would be better suited for surgery, what would you say to that patient if they outright refuse to have surgery?
The patient is the decision maker at the end of the day. My philosophy for patient care is very simple. Provide the best up-to-date knowledge and information available. Give them what are the pros and what are the cons. At the end of the day, patient who decides what they want to do. I have some patient who decided not to go for surgery. I have a lady who was in a show business. I'm not going to name her. She did not want to have surgery. And she came and I told her that it's going to take 2 settings. We will be able to do it and we'll take care of it. We have done 1 setting on her with her. And in fact, we had a call from her today and she is able to sleep, swallow easily, be happy about it. We did recommend her that she should have surgery. Said, no, I'm not going to have surgery. I don't want a scar on my neck. So we did it. At the end of the day, it's the patient who makes the decision.
That's a wonderful outcome for that patient. I'm sure you recall when I told my story when we first met in Fort Lauderdale, I was similar in my motivations to not have surgery because I had a terrible surgery experience. And I was afraid of what might happen to me if I had another surgery. So I think a lot of doctors who either do surgery or are accustomed to surgery, they see a lot of people go through surgery and do just fine, are not as concerned about the issues that may arise from surgery as someone who's maybe gone through one and had a bad outcome. Having been through it yourself, not necessarily a surgery, but a negative situation with your thyroid, I think you have that empathy that the patient is looking for. And so that's a wonderful thing.
I will definitely offer anything I can, which is minimally invasive and with the quality of their life and sense of well-being and satisfaction. At the end of the day, it's a satisfaction.
So let's talk a little bit about how you ended up deciding to provide laser as a treatment option for thyroid nodules. How did you encounter it? When did you start doing it? And how many cases have you done so far?
It was, I think, 2016 or 17 when at a conference, there was a stall which was showing the radio frequency from, I think it was some Korean company. I don't remember which company was that. And that really fascinated me. I wanted to bring that in my practice yesterday, that day. I mean,
yes.
But when you're employed and when you're working in a system, they want to know what is the background and what is the data and if there's any data to support it. And plus, definitely surgeons at that time did not support it because of this reason. So it was a long struggle, keep on pushing for it, and ultimately ended up being an independent. I joined, ironically, a surgery group, highly specialized surgeons, and I joined them as an endocrinologist who had interventional skills. They were very supportive of it. They were really, really supportive of this. Dr. Thompson, he's my friend, he introduced me to the laser, this is another alternative. Laser frequency ablation, you do need conscious sedation. With the laser ablation, I've never used conscious sedation in anybody. Nobody ever had even a cry for help or pain, or it's been working extremely well. And I have
Mhm.
the 1 month follow-up average so far, I think, is about more than 50% reduction in the volume in first month. And almost all the patients so far, they don't have any compressive syndrome anymore. Gratifying that you do something that it makes you feel that you have done something very important in somebody's life.
Wow, that's great. And how many have you done so far?
I've done over 25. I started doing it last year. Laser is relatively new. And like I said, I think I'm the one who've done the most. And I think I've over 50 booked already.
Oh my goodness. That's fantastic.
Everybody, every day, somebody's calling. I'm finding a little bit difficult to find a place. I'm hiring some people to make room available to get it done. So my ultimate plan is that I'll be doing all three radiofrequency ethanol ablation. I've been doing it for a long time. Laser ablation. And like I said, I love it. And the fortunate thing is that the endocrine surgeon I'm with, she's all on board. And I think we're going to present a unique team, which is not elsewhere in the country, actually.
I love the idea of having the balanced perspective of both surgical and non-surgical interventions, because you don't have patients thinking, oh, well, they're just selling me this because this is the only thing they do. You have all of the tools in your toolkit, and you can provide literally the best possible option for that patient based on what's available.
Absolutely. Based on my experience, that any nodule which is less than 2.5 or around 2 should not be causing any symptom of difficulty swallowing. Now, having said that, there are some patients who have 1 centimeter nodule and it is causing significant discomfort to them. I have not done anybody with 1 centimeter yet because I don't want this to be a kind of a just money-making thing. I just want to do this for patients who are really, really symptomatic. Anything less than 2 centimeter, 2.5 centimeter, at this time, I'm trying not to do it.
I think that most people who come to our group with nodules that are smaller than 2 centimeters that have issues are the ones with hot nodules.
Hard not. Yeah, that
In those cases, would you treat those nodules that are smaller than 2 centimeters?
absolutely, I will do it. I've done it.
And what's the outcome with laser on hot nodules?
I don't have the final data as of yet,
Mhm.
but based on assessment of the patient individually that I've seen, the nodule size reduction starts within first month. Vascularity diminishes within first month tremendously, but the thyroid function test takes a little bit longer time, 3 months, something like that, to normalize. Maybe I'm doing something not right. I don't know. I just have to find out. Like I said, thyroid is a very mystic gland. The levels are improving. Why it's not happening that fast, that I don't know yet.
I think it just really, it varies a lot depending on how active the nodule is and how large it is. And I know of one particular patient, I think she's had 2 RFAs and she's still kind of having some issues. Some of the nodules I'm sure are pretty stubborn.
Yeah.
I think even with a reduction in medication, if the patient's on a anti-thyroid medication, that even that's preferable to maintaining.
Most of the patients are off of the medication after a month and a half or so.
That's
Most of them.
good.
It does work pretty good, actually.
You're so excited about this. Are you having any physicians come and observe your cases? Or are you going to train any physicians?
I am. I mean, I'm training people, actually.
Nice.
A physician came from North Carolina and a physician came from Ohio. And this is a knowledge that I want to share with everybody. I mean, whoever wants to come and learn, they're more than welcome to learn. Not only this, if they want to learn about the ethanol ablation, I can teach them that. You see, there's a room for everything. And if you try to utilize one thing when it is not the best, don't.
I think that the quote, if you have a hammer, everything looks like a nail, is very applicable here. You want to have lots of different tools, screwdrivers, hammers, wrenches.
Everything to provide the best care, definitely.
And, you know, regarding the ethanol ablation, I interviewed Dr. Andrade about that topic recently, and he was so frustrated. Ethanol ablation is not more prevalent and widely used because so many people are having surgeries for cysts. And, you know, for thyroid cysts to be removed surgically, to me, seems even more overkill than for benign nodules, because they're nearly always benign.
Absolutely. I think those patients are the most gratifying, the one because the volume reduction in those patients is tremendous and instant. At the end of the day, it works really, really, really good. Somewhere along the line, the endocrinologist dropped their skills and they just let the surgeon decide what they have to do. We are trying to get it back.
I spoke with a patient several years ago, and she said she had a large thyroid cyst and was going to have surgery. And I said, well, why don't you consider doing PEI? And she was saying, oh, my doctor recommended against that. The surgery is going to be just fine. She was adamant that she wanted surgery. Fast forward to several weeks later, and she was commenting about all of the problems that she was having because she lost some parathyroids and her calcium levels were off. It would have been so wonderful if she could have avoided that heartache.
I mean, it's unfortunate. I mean, most of these surgeries end up nice, but sometimes you can have complication from the best hands. When that happens, I really feel ache, actually, to be honest with you. I personally feel the ache. And if any way we can reduce the possibility of that.
Yes, absolutely. You've already talked about the minimum size. Is there a maximum size that you would say, I probably wouldn't feel comfortable going over however many centimeters in treating that nodule?
I don't think I will say no to a bigger nodule because I think those are the patients who will benefit the most, and they are actually easy to do, actually. Much more room to work on, and the chances of complication, in my view, are smaller in comparison to smaller nodule, and especially if they are in areas you're likely to get in trouble. And I've done one nodule which was like 12 centimeter, I think, in one dimension.
Wow.
It was a big nodule. So it had a part which was submerged down and this upper part. So my plan is that I'm going to ablate the upper part because it's going to shrink. The lower part is going to be pulled up. Easier to perform the laser of that part.
That was my experience. And I think that's worked for a lot of patients.
So you just have to be a little bit tactful how to take care of those. In laser, you can use more than one fiber at the same time. I don't tend to use more than one fiber. Why? Because I want to pinpoint each spot where there's a vascularity. And it becomes very difficult for you if you're using more than one fiber, especially in hyperactive nodules. It takes a little bit longer time, but it works much better if you just use one fiber and you pinpoint the areas where you want to ablate. When you're using two fibers, you don't know, okay, where was the boundary? So I kind of use the laser a little bit more like radiofrequency, but it's a little bit different than radiofrequency though, but utilize the skills of radiofrequency in this one too.
You're kind of blending the two together and making the most of it. That's very interesting. So do you place the fiber and then pull back as you're treating? Is that how the process works?
Yes, you assess where the tip of the needle should be, and it's going to be not damaging any structures, and then you pull it back. The fanning, all those techniques, you do that. And then sometimes, you have to use very awkward angles. With the radiofrequency, mostly you approach from transisthmic, but with the radiofrequency, you have ability to approach from different angles at that leisure with the laser. So both have their own plus and minuses. I'm not going to be arguing that one is better than the other one. I know there's debate going on out there. I think both are better and both are pretty good. Depends how you use it.
And I definitely think that there's a place for both, because I think that there are certain patients that might be better suited to one or to the other. You said you've had quite a number of patients coming and you've got more scheduled already. Are they coming mostly from your local area? Or are you having patients travel from out of town?
It's a mix of the two, but mostly are local. And as I've not spent a single penny on advertising or telling people or Facebook video or anything. I've not done anything.
This is all just word of mouth?
Word of mouth. And
wow.
Patient coming from the kind of corners of the Wisconsin now, Milwaukee, Madison. I've seen two patients coming from those bigger. In fact, one was sent by a major big hospital in Milwaukee. They said, we don't do it. He does it. Go to him. So I don't know how they found out I'm doing it. She's the same lady that I mentioned that she is in show business. She's very, very happy.
That's wonderful. Patients are motivated to do this.
They want to pay. You have to pay out of pocket, we'll pay. But okay, people will let's see. And if you is it good for you or not?
Let's talk about that, because one of the big things about laser that's so exciting is that there is actually a CPT code for billing. Have you had any success with that yet, or is it still a cash pay procedure?
No, I have not charged any patient cash, any patient. Insurance companies are paying it. and it's reasonable, and I'm very satisfied with that. So I am happy about it.
Wow, that's great.
So I think there's a problem with RFA. That's why I'm not doing many of those. They have to pay out of their pocket.
I really hope that they'll be able to get a code for RFA soon. That's a frustration for so many patients. But at the same time, there's a lot of patients who are just so motivated to do this, they really don't care. They're more interested in saving their thyroid than anything.
I was surprised that I didn't have much hope. I just wanted to start it. I started last year, and a couple of patients. Actually, to be honest with you, one of the patient was paid by insurance last year, actually. Hit and miss last year. But this year, all the patient that we did, all of them got paid. And
Wow.
I think the patient did not have much out of their pocket. It's been going pretty good, actually.
That's fantastic. And
Yep.
you know, the long term for a physician, it's important that you are able to cover your costs on this. And that's my concern for RFA physicians is that if the insurance companies decide they're going to pay, but then they don't pay enough, you know, the physicians are not going to be able to cover their costs. So my hope is that when they do start paying, that they pay enough and that this continues to grow in prevalence.
Yep. And so far, like I said, I mean, it's been, if we are able to cover for the cost, this is reasonable. I mean, we are satisfied with that.
Tell me a little bit about where you're located in Appleton, Wisconsin. Is that a major city? And are you near any other major cities in Wisconsin? Forgive me, I'm not familiar with Wisconsin at all.
You know, it's interesting that I was trained in New York, and actually initially in Oshkosh, actually, a smaller city next to Appleton. And it was such a, not a change of city, it seemed like it was a change of universe. But, you know, we love it. And it's such an amazing community, a nice place to raise the family. Appleton, Neenah, Menasha, then Oshkosh. There's no clear boundary between these two cities, all these
Mhm.
cities. The population is about 200 plus, so it makes it a kind of a mid-sized city,
Yeah.
collectively metropolitan. There are a lot of different nationalities. There are people from every corner of the world here. So it makes it a very interesting kind of a small cosmopolitan melting pot. We love it, actually. If it's only if it was not that cold.
It's a wonderful thing to have access to things, but it's not such a large city that it's difficult to get around and it's overpopulated. And so for patients coming to Appleton from out of town, that's a nice draw that they're not going to feel overwhelmed like they would if they were traveling to a really major city. I'm sure it's probably less expensive to stay overnight in a hotel. I'm not sure. Is there a major airport there for anyone who would maybe fly in from out of town?
Yeah, there is airport, Appleton regional airport,
Mhm.
and there you can go anywhere in the world, actually. This is a town where you will not find the traffic, very well organized. Everything is available. All the amenities of life are available. And the healthcare system in this area, we take a lot of pride on it, by the way. I mean, I have worked many places. I believe I became much more better physician working in Appleton, actually. I was surrounded by the physicians who had very high standards for being a physician, providing the excellence of care. For example, I mean, in our practice, if there's a patient who had result labs today, they will have the reports called today with the recommendations. There will be no delay. Most of the time, it will be done at the same time, and we will tell them in the office visit what is the plan. But if some labs, I mean, you have to wait. If somebody calls that we have a problem, the patient will get called back within 15 minutes. If they leave a message, 15 minutes. So we have set a certain standards. I really feel the healthcare in this area is exceptional because the kind of physician who were before me, they kept the certain level of excellence that you need to
Mhm.
follow, and that just becomes your second nature. You just want to be like that.
Patients appreciate that so much. You know, the anxiety that comes from waiting for a very long time between biopsy to results to treatment options, the time span can sometimes drag on and on and on. And the further the time lasts, the more the anxiety grows. And so limiting that as much as possible is such a wonderful thing for helping the patients experience that higher standard.
You have to. I would not compromise this quality at any cost. This is, I mean, I've worked for last 10, 12 years, worked for this, and I'm not going to compromise on it.
Do you have any final thoughts you want to share just about yourself or your practice or laser or anything on your mind that you want to share that we haven't talked about yet?
I know there are a lot of things in the future that we'll be doing with this radio frequency and laser with respect to thyroid and parathyroid. I mean, my specialties are two, thyroid and parathyroid. In high-risk patient, I also use laser to ablate the parathyroid. This is kind of my passion. When I came to this country, my father told me, "Oh, you're going to that country. Why are you going there?" I'm going there because I want to make a difference in the specialty or the profession I am. And he said, then you should go. If you're just going there, just like any other position, then you don't need to go. Take care of the business over here. This is my obsession that I want to make thyroid and parathyroid center of excellence before I retire or before I go out of the picture. So this is my kind of theme, and I've been working tirelessly. People have made joke about me that I'm crazy, but crazy, I've come so far. I think I'll make it happen.
When you are very passionate about something, it shows. And it very much shows in you, Dr. Malik. I'm just absolutely thrilled to have heard everything you've said today, and your passion is just very clear and obvious. So thank you for everything that you've just explained and shared with me today. This video is going to reach even more patients than what you've been reaching already through word of mouth. And I don't doubt you're going to be getting even more phone calls.
The surgeon, Dr. Janelle Mitchell, she is also, will be a part of it, and she will be also doing these. She's on a maternity. She just had a baby boy. We have a surgeon and endocrinologist. We sit down together and make a right decision about the patient. Okay, what is the right thing for this patient? This is something which probably you can get in Mayo Clinic, nowhere else. Individualized plan of care for every patient.